So this is going to be an interesting debate because, and I'm the underdog. I mean, I'm just an average intensivist who reads a little bit here and there. And of course, I'm going to be debating Charles Sprung, who's done all the work on steroids, and all the way from 1970s, right, and 1980s. And before we start off, we say that whether steroids are effective in severe sepsis and septic shock. Let's get a few things straight. When you say something is effective in some condition, you would be really stupid to say that it is going to be useful in each and every patient with that condition. I mean, nothing in medicine works like that. There are some groups who are likely to be effective, there are some who's not going to be effective, and maybe some who are going to be harmful. Now, of course, first, we are not going to talk about patients who need steroids for medical reasons. We are going to talk about steroids purely and precisely for the treatment of severe sepsis and septic shock. So then we have to ask, what do you mean by effective? Are they effective in reducing mortality or in reversing shock or some other parameter? Obviously, we're not going to, so if we say it's useful in some patients, not all, then therefore the debate's over. I think that's a silly debate. I mean, let's say that yes, it is going to be effective, but in some patients. And we have to identify which patients. The problem is it going to be effective in a majority or a large proportion of patients or a small number? And that will sort of guide us as to what we should do when we've got severe sepsis and septic shock. And we also need to consider whether they're actually harmful in some patients or all patients or most patients. So we sort of go along these parameters. Now, the way we understand sepsis, and believe me, we think we understand a lot about sepsis, but our knowledge and understanding of sepsis in the body is really quite limited. And this is a very, very simplistic way of how we've understood sepsis in all these years. We say it's a balance between the inflammatory forces, that is SIRS, systemic inflammatory response syndrome, and the counter anti-inflammatory response syndrome. And if for some reason you have got more inflammation than counter-inflammation, and you therefore end up with the huge septic syndrome and you get septic shock, the patient turns very sick. And that is why you should give steroids, because and that was the understanding many, many years ago. And Dr. Charles Sprung was one of the leaders of that sort of philosophy. So you have the steroids, they actually decrease inflammation. They decrease the mediators, they act on various cell types, which therefore, at the end of the day, you get a net suppression of inflammation. And if sepsis is a disease with massive inflammation, then giving steroids should probably help the inflammation. There is another role that steroids have, and that is that they actually improve vascular reactivity and the responsiveness to catecholamines. And if you give steroids if you give catecholamines, they may actually become more effective in the presence of steroids. And therefore, so you have improving the hypotension is one of the important reasons why you might want to give a steroid, and diminishing inflammation would be another reason why you would want to give a steroid. Now, in the 70s and early 80s, the predominant mechanism was thought to be anti-inflammatory, and the therapy was tried to slam the inflammation. So you give a big whack of steroids, and when I joined intensive care, they said, oh, you must give the shock pack of steroids, 30 milligrams per kilo of methylpred, or 16 milligrams of dexamethasone, or 32 milligrams of dexamethasone. Give it a big whack, 2-3 doses, and the patient will be absolutely fine. And this is what the Schumer study seemed to show in 1976, the first one. Then came the study by Dr. Charles Sprung. And from then the downslide started of steroids in septic shock. Their study showed that there was actually no problem. There was no benefit at all when you gave high dose steroids. And in fact, the mortality tended to be a little higher with steroids rather than lower. Although there was some early shock reversal, but no overall difference in mortality. And then several studies came which sounded the death knell of high dose short courses of steroids in septic shock. So we are not going to talk about high dose and short dose of steroids. Even I am convinced that they just don't work. All right. Then when we left aside the anti-inflammatory, because of course this meant that inflammation was not necessarily the best target for steroids, then came another target for steroids. And then this concept of adrenal insufficiency came in. And there were a number of small studies. And I'm quoting this study because it was done by an Indian, Zarir Udwadia. He did, of course, in the UK, but he was an Indian and he's now practicing in Mumbai. And they did the ACTH stimulation test to assess adrenal function in 32 patients with septic shock. And those patients who had a poor response died, and those who had a reasonable response, less patients died. And that sort of suggested that, there is some adrenal insufficiency, there's relative adrenal insufficiency. At rest or at normal times, there's no problem with the adrenals. But if you develop septic shock, develop severe sepsis, then the adrenals are not able to maintain the output that is necessary to maintain life and homeostasis, and therefore you need to supplement steroids, not give a big whack, but just give stress doses or supplement steroids to help the adrenal function in these, help the adrenal hormones in these sort of patients. So now we have reasons to give steroids, and we have developed this term which is called CIRCI, right? Critical illness related corticosteroid insufficiency. And there are various reasons why you might have insufficiency of corticosteroids when you are critically ill, starting with impaired release of corticotropin releasing hormone and ACTH, maybe from injury, maybe from previous steroid therapy, impaired release of cortisol from the adrenals. And etomidate seems to be a big important reason. It's seen in almost 20 to 25% of patients in the large studies that have come out from the international era, but we don't have etomidate here, so we are not far too worried about etomidate. Tuberculosis is something we do worry about because a lot of Indians have occult TB in the adrenals, and we don't know it, but maybe they're insufficient because of that. There is increased breakdown of cortisol when you're septic, and lastly but not least important is there's probably some element of tissue resistance to corticosteroids. And these patients actually have high levels of steroids, but they're just not effective. And then the diagnosis of this corticosteroid insufficiency came by looking at the baseline plasma levels of cortisol and by the response to a ACTH stimulation test. And if the rise is less than 9, then you say that this patient is not responding to steroid, to ACTH, and therefore has adrenal insufficiency, and these patients need replacement therapy. There are patients who have a high cortisol rise in response to ACTH, but if the cortisol response is very high, more than 34, then it might actually suggest that the tissues, they're responding appropriately, but the tissues are not utilizing the cortisol well. There is some element of tissue resistance to cortisol, and these patients also need further steroids to sort of boost their tissue levels up. And this was nicely studied by Anand. And Anand is a name, and actually, if you say we are debating on steroid and septic shock, I'm a proxy for Anand, because all the studies done by Anand have been positive, and all the studies done by Charles Sprung have been negative. So we are going to, so when Anand actually studied adrenal cortical responses, he found that if you had a basal cortisol less than 34 and a delta, a change in response to ACTH more than 9, you were quite okay. If you had a change less than 9 and a basal and a response more than 34, it actually meant that you were both adrenal deficient and resistant to steroid cortisol, and that those patients had the highest mortality. So to put it in a nutshell, adrenal insufficiency or adrenal dysfunction or relative adrenal dysfunction in severe sepsis and septic shock is a reality, and maybe to some extent the mortality may depend on how severely affected your adrenals are, but we'll see about that. So now, so this sort of philosophy caught on. So they moved off from the anti-inflammatory bandwagon and jumped on to the adrenal insufficiency bandwagon. And then there were a number of small studies which were done using smaller doses of hydrocortisone over slightly prolonged periods of time. And these were studies by Briegel, which showed that you were able to reverse shock faster, less time spent in shock, you came off vasopressors faster, but no difference in overall mortality. But again, they were looking at small numbers of patients. Okay, and they were not really looking at large numbers. And same thing, another study which is often quoted, only 41 patients with catecholamine requiring shock for more than 48 hours. And again, those who did well, got steroids, came off the vasopressors faster. But again, now this study showed there was no difference in outcome between responders and non-responders to the ACTH stimulation test. So again, there's a bit of a paradox over here. Then came the big one. This is Anand's study. And this is a study which all of us, when we saw it in the 2000s, there were so many other interventions in intensive care that came up at that time. And everyone was caught up in the euphoria of that. Now we've got some battle, we've got something to do for sepsis, we've got tight glucose control, we've got activate protein C, we've got early goal-directed therapy, and we've got corticosteroids for septic shock. Now, Anand studied 300 patients, which was a large study in those days. These patients were quite sick. They had to have a systolic BP of less than 90 for at least 1 hour, more than 1 hour, okay, despite adequate fluid resuscitation, and to be on vasopressors, okay. They were on mechanical ventilation, and they were randomized within 8 hours from the onset of shock. So they were early, severe septic shock, on vasopressors. Okay, and they got hydrocortisone and fludrocortisone. Now they found that 76% of patients had adrenal hypofunction. So that would mean, and 20 or 25% of patients had received etomidate. But 76% of patients having adrenal dysfunction is actually quite a large number. I think usually it would be in the range of 40 to 45%. So maybe they were very sick, maybe there was some contribution from etomidate or other sort of factors, we are not very sure. But what they found is that if you were a non-responder, meaning you did not increase your cortisol level in response to ACTH, then there was a higher mortality in the placebo group, a lower mortality in the corticosteroid group. Vasopressors came off faster when you got steroids. Okay, and if you were a responder, means if you had adequate adrenal function, there was no difference between the groups. So essentially, if you were a non-responder, if you had adrenal dysfunction, and 76% of patients had adrenal dysfunction, you tended to do better in terms of mortality, in terms of survival, and in terms of coming off vasopressors. And at that prompted the Surviving Sepsis Campaign guideline to say that you should give hydrocortisone in septic shock, refractory to fluid and vasopressors, because that is the group that Anand was studying. They were septic shock, they were receiving vasopressors, and they were still hypotensive, right? So that is group of patients. So remember when I said we have to identify the group of patients we are talking about, this is a group we are going to talk about, in which steroids are going to be effective. And you give low doses, 200 to 300 milligrams per day, only for 7 days. So it's but not for 1 day or a 2-day course. So it's a low dose or a medium dose, medium duration infusion of steroids. There were no great recommendations whether to taper the steroid or to just shut it off after 7 days or stop it when the pressors came off. So there was a little bit of a controversy after that. And so there was a comment which was made in critical care saying that in the early 1980s, we were big proponents of using corticosteroids in septic shock, whereas in the late 80s, we thought corticosteroids were a bad idea. And that's the anti-inflammatory mechanism. And then he said that in the typical septic shock patient, based on the data we already have, now this is in 2002, okay, after Anand's study, given the frequency of adrenal insufficiency in this population and lack of a downside to the use of lower doses of corticosteroids, the routine use of corticosteroids is probably beneficial. And guess who said this? Okay, Dr. Charles Sprung. Now something has made him change his mind, and it was probably this study which he led and which he published, and it's a great study. It's the Corticus study, and this was published in 2008, and this was again a large double-blind multi-center randomized controlled trial. And at this stage I want to come back to what Dr. Todi said in his opening remarks. He said, you know, this is a pendulum, it's swinging this way and it's swinging that way. In fact, and the clock keeps ticking, and that's a good sign. Now, I don't think it's a pendulum which is swinging with regularity. It goes on one extreme, gets stuck there for a few years, then it comes to the other extreme, gets stuck there for some years, and it goes back to that side, and again it gets stuck for a few years. So it's not a ticking clock. It's a, I don't know what to call it. It's just going from one to the other, getting stuck, going back again, and so it's sort of going back and forth. And this is sort of almost like a yo-yo. So now we've got this Corticus study which comes up and says that these patients who are systolic blood pressure less than 90, they did not have to be vasopressor dependent, though most of them were on vasopressors. I think 99% were on vasopressors at the time of randomization. They could be randomized within 72 hours of shock. So not within 8 hours, so not early, but they could be in shock for 72 hours before they got randomized. And they got only hydrocortisone, they did not get hydrocortisone plus fluorocortisone. They just got hydrocortisone, and they did ACTH stimulation tests in everyone. The duration of steroid therapy was slightly longer. In Anand's study it was 7 days, in this study it was 5 days, tapered over 6 days, so a total of 11 days of steroid therapy. Okay, and in this study only 47% of patients were adrenal insufficient. So as compared to 76% in Anand's, only 47% were adrenal insufficient, and this study was essentially an absolutely negative study. They found no differences in 28-day mortality in hydrocortisone versus placebo, whether you were a responder, whether you were a non-responder, and overall. There was just no difference between the two groups. So there was no difference in shock reversal overall. But if you reverse shock a little faster if you got hydrocortisone. But that's a small sort of minor point. They found a higher incidence of super infections and new sepsis, which is bad because this is a complication. Anand's study and several other studies did not find any new complications, new sepsis, new infections, extra infections. But this study definitely found more infections and new sepsis in patients with received steroids, and there was no increase of neuromuscular weakness. So the major complication that they encountered was super infections and new sepsis. So if you sort of look at trying to compare and try to figure out, oh God, Anand was positive and we all did Anand and we all did steroid, and now this corticus comes up and they say no steroid and everything's useless and they just don't seem to work, whether you're a responder or non-responder, doesn't matter what's happening. And at the end of the day, people like us, what do we do? I mean, do you believe Anand or do you believe Charles Sprung? Now Anand was here in Bhopal, so we started using steroids. Now Dr. Sprung is going to come here in Delhi and we're going to stop using steroids. Again, we're going to go up and down, up and down. So let's try and figure out what's happening over here. Okay, so there were differences in duration of treatment. The patients in Dr. Sprung's study, in the corticus study, were definitely less severely ill. The SAPS-2 score was less. They did not have to be vasopressor dependent. Okay, they had less patients who were adrenal insufficient, only 47% versus 77%, and that may have to do something with severity of illness. I believe the number of patients who got etomidate was similar in both the studies. The patient mix was different. Anand's patient was largely medical and pneumonia, 60% and plus medical, and here 60% was surgical with sepsis in the abdomen. Now abdominal sepsis behaves, I don't have objective data to support that, but in my experience, abdominal sepsis behaves differently from a pneumonia. Abdominal sepsis tends to be rumbling, something left going on, something keeping on going on, a little rumbling, low rumbling sort of sepsis, flares up once in a while, do a surgery, comes out of control, flares up again after some time. Tends to behave a little different. So maybe that might account for some of the differences. And at that time, people said, well, no, steroids are very bad, till Anand came and did a meta-analysis. What did he do? He put all the studies together, including his study, including the corticus study, and several other studies which were published. This was not usual meta-analysis. They made attempts to look at all papers, irrespective of language. So they included papers which were in the literature, regardless of language. They also try to get unpublished data. So if they knew people, and I suppose everyone knows everyone in this sort of field, they try to get data from people who are doing studies who had not published. They contacted authors for additional unpublished material. So if they wanted some clarifications, they got it from most of the authors. They assessed the studies methodologically and they included 22 trials, starting from the old studies of high-dose steroids down to the current sort of studies. But this is the meta-analysis of a predefined group of low-dose, longer course of steroids. And in this study, what they found, in the meta-analysis, what they found when they put all the studies together, including corticus, including the Anand study, was that there was a benefit in terms of 28-day mortality. There was a 16% reduction in relative risk. There was no heterogeneity between the studies, which means you can roughly believe this magnitude of effect. Okay. So if you put all the studies together, including corticus, there still seems to be a small benefit to the use of corticosteroids. Shock reversal, definite benefit. Okay, whether you use at day 7 or at in low-dose steroids. So there is shock reversal, there is a mortality benefit, and yet another meta-analysis was done which used a Bayesian sort of method. And I cannot talk about this meta-analysis because I don't understand the Bayesian method very well. So I can be attacked on this one. But what this study concluded was that although a null effect for mortality efficacy of low-dose steroids in severe sepsis and septic shock was not excluded, and it's possible that there was no effect, but there remained a high probability of treatment efficacy. So now we've come to this, we are somewhere stuck in the middle, right? So we started with high dose, we said no. We started with high dose first, we said yes. Then we came here, we said no. Then we said low dose. So we came back here, yes, low dose. Then we came back here with corticus. No, not even low dose. Now we are somewhere here with a meta-analysis. And now I think we'll ask Dr. Sprung to take over. Thank you.